Yes, so I would like to thank the organizers for the opportunity to present the results from our lab here. And I would also like to say that this is my first presentation on an international meeting, so overall I am very, very, very honored. So my name is Milena Baščarević. I am a molecular biologist with a specialist academic degree in microbiology and am currently enrolled in PhD studies in molecular medicine at the Faculty of Medicine, University of Belgrade. I have no conflict of interest to declare. So first I would like to say a few things about our lab. I work at the Department for Medical Microbiology at University Clinical Center of Serbia. It consists of many sub-departments, in particular the Biosafety Level 3 lab, FireEye, which was opened during the pandemic, and the Laboratory Department for Virology, which is an HIV reference laboratory in Serbia, along with the Virology Department of the Institute of Microbiology and Immunology. I won't focus much on the statistics and history of the HIV epidemic in Serbia, since Marina did a very good job summarizing that. So I will move on to the situation today. So this graph shows the newest data from our Institute of Public Health, and that also, I think, might have been your previous question. It is a bit difficult to sum up the trends in the last few years, as you can see from the picture, whether it's steady or increasing or decreasing, but in any case, AIDS cases and specifically AIDS deaths are definitely in steady decline. What is also characteristic is the heavily skewed male-female ratio, with men being 9 times as numerous as women, and the vast majority of people falling in the 15 to 49 age bracket. Diagnostics of HIV in the University Clinical Center of Serbia is comprised of serology, PCR testing, which is quantitative and which is done on 3 different automated systems from Abbott, Roche, and GeneXpert. And since the March of this year, we have also started doing the next generation sequencing of HIV-1 whole genome. So since then, we have analyzed 47 samples. The median viral load expressed logarithmically was 4.84, with the range being 2.84 to 6.95. The ratio is heavily male skewed, as I said previously, and samples were mostly blood samples, with a few of them being cerebrospinal fluid. Also, approximately 2/3 of the samples were from ART-naive individuals and approximately 1/3 being from ART-experienced patients. Median age was 39, with most people being between 20 and 45 years old. And regarding the place of origin, it was mostly Belgrade, since most samples that come for analysis into our lab stem from the other departments from University Clinical Center of Serbia. And I don't know if you can see, we also had 1 patient from Nigeria, here between Kučevo and Mladenovac. So, the process of NGS HIV-1 whole genome sequencing starts with the sample selection. We only ever analyze samples which are explicitly requested by clinical practitioners, and only if they fulfill the minimal viral load, which is per manufacturer's requirement of 1,000 copies per milliliter. That is checked through PCR testing on one of these platforms, and then optionally frozen at -70 degrees. Then a sample extraction is performed using, again, per distributor's recommendation, the automated Abbott M2000 SP system, and the extracted RNA can also be frozen at 70 degrees until later time. We use the commercial library preparation kit from DeepCheck. So that's DeepCheck Assay Whole Genome HIV-1 genotyping and NGS library preparation and adapters. The sequencing is done on the ISAC 100 instrument, and the sequence analysis is performed by a commercial DeepCheck software. So what we have found is the dominant prevalence of B subtype, which is in accordance with previous findings, while the second most dominant subtype was A6, found in a total of 5 out of 47 samples. And in 3 out of 47 samples, we have found the A1 subtype. With regards to co-receptor tropism, 3/4 of samples had R5 tropism and 1/4 had a dual mixed. Here are the sequencing results with regards to the presence of high or intermediate level resistance mutations. So for the purposes of this analysis, we considered all samples which have at least one high-level resistance mutation to any of the drug categories to be resistant, while only those with complete absence of any intermediate or high-level resistance mutations were categorized as sensitive. And as you can see, at 20% threshold, the overwhelming majority of samples are sensitive, with around 9% being resistant. When we lowered the threshold to 10%, the biggest difference we can see is in the intermediary level resistance mutations. So that jumps from 21 to 32%. And when we lower it yet again to 3%, there are no more samples which can be under that criteria considered sensitive. And moreover, almost 80% of samples have at least one high-level resistant mutation. So that's that difference. Also, what was perhaps interesting was that we found in 21 samples, so almost half of them had high resistance level mutations present in all categories of integrase inhibitors at 3% level threshold, while being mostly sensitive at the above 20% threshold. And one sample being resistant to all but one non-nucleoside reverse transcriptase inhibitor, while being ART naive. So that would be interesting to follow up. And this is what it looks like in the automatically generated report. So here you can see the most common, or all actually, all drug-resistant and APOBAC mutations, with the most common one circled in red. And also among the integrase inhibitors, we thought it was the presence of L74I mutation was interesting because that one is associated with the A6 HIV-1 subtype. It is also interesting that we have found 2 mutations in a total of 8 samples associated with capsid inhibitor resistance, despite lenacapavir not yet being available in Serbia. As for recombinant forms, these are the 3 most frequent, previously documented and well-described recombinant forms that we found among our samples. So one of them is 64BC in the P7 region of the genome, which was detected in 5 samples. 99BF1, also in the P7 region, detected in 3 samples, and 03A6B, detected in either P7, P24, P17, or protease regions of the genome in 5 samples. In conclusion, the introduction of NGS technology enables high sensitivity and pretty high specificity in deciphering the HIV-1 genome. And also, whole genome sequencing is very important for the epidemiological surveillance and discovery of novel emerging subtypes and recombinant forms of HIV viruses. And finally, sequencing data analysis at lower thresholds gives way to detecting low-frequency variants, which could be a source of an emerging drug resistance. And in the end, I would like to thank my colleagues and co-workers and senior doctors from our lab, which have all together contributed to the successful introduction of this method in our lab. So thank you for your attention.